I haven't allocated much time for this. In fact, we'll try and keep this a little shorter than 2 hours, because I want, if people have to do this, I think it's nicer to do it more often and have simpler meetings. So it's going to be Mukul, who's, we are proud of him actually, who's somebody we got with the same mind and very interested and excited about pathology. A pathologist should be, but he's extremely excited about it. And we're having Radhika and Karan who are going to show the case scenarios actually. Today, I think I'm keeping it to the basics and also keeping it to common problems that you will face. I'm sure every case that we are going to present today, you've come across, and also to show that how really looking at pathology makes a difference and gives you the confidence to do or not to do how you want to manage these patients. We start with something very basic, and I'm sure the younger generation will enjoy it because actually, I don't know, Mukul, if I should say that, histopathology is simple. It's fairly straightforward. And it helps you enormously to make decisions. And sometimes when I read reports and see a patient in front of me, and I don't have the confidence that the report fits with what the patient's experience is, I always tell them I will go and see the pathology myself and come back with an answer. So sometimes we have the advantage of having the patient in front of us, having the liver function test in front of us, and then the pathology in front of us. So the decision making is much easier for us because everything is in front of us. So I would like all liver transplant physicians, the surgeons, the clinicians, to have an interest in pathology, and you can make much better, confident decisions when you are managing complex patients. So let's start. Radhika and Karan, thank you. And I'll leave to Mukul to decide in what format he's going to run it. Go on, Mukul.
Prof, thank you, Prof. Thank you, LTSI. Thank you, Prof, for this. And yes, so what we decided that first we'll talk few minutes. We'll talk about the basics of liver pathology. I'll try to show you a normal liver, in which just to show you how's the architecture of the liver is, and then we'll go on to the cases. So I'll share my. This is again, these are all scanned images. There are no static images here. We have the scanner with us. So I will share the. Yeah. My
So
sharing is not
this
turned
is
off.
the advantage of this meeting. We have actually as though you're going to look through a microscope. So that's what you're going to see today. In fact, it's a slide scanner. So you see the slide and he will magnify it. They are not fixed images that he's going to show and say, this is what it is, that is what it is. So you'll actually see it like you're looking at a microscope. Thank you.
So I'll share my screen. So is this visible?
Yes,
Is
you
this
can, yeah.
okay. So this sorry. No, it's not moving. Okay, I'm not able
You got a powerful computer there.
But I'm not able to move it. I'm not able to zoom in and zoom out. Can somebody it's not responding, it's saying. Should I wait? Somebody can
I think you can reload it.
Reload it. Okay.
Yeah.
Okay. Sure. Oh, okay. Let me. Is it? This is here.
Choose another view and then see.
Prof, I'll see.
Yeah, now it's there.
Just a second, Prof. Sorry. Just Prof.
The device is ready to pair.
It's not, Prof. It's not able to. I think. Am I audible?
Yeah, you are.
Audible.
Okay, so I thought to show you an explant liver, which was a metabolic disease in a pediatric, to just show you the concept of lobule, because I first thought that probably I'll show you the, because in the report you will see that the report is there is central lobular area and periportal area to show you the lobule, but somehow that I'm not able to open that image in this. This is working for me.
Okay,
So this
let's go to the next one then. Yeah.
Yes, yes. So this to show you, this is a biopsy from a donor. So normal liver we are not going to get. So we get sometime biopsies with some issues, either enzyme raised slightly or there is some antibody positive, and so they do biopsy to look for, and sometimes for fat also. So this was done probably for certain there were some issues in the patient, in the donor, living donor, and they did a biopsy.
Can we just start? Are you going to present the first case, Radhika, or
Okay, sir.
Prof, this is the just to show them, Prof, just to show them the normal liver, the portal area and the central vein.
Okay.
So this to show you, this is also just to show you normal things. So you can see here, you can see a portal tract here, you can see a triangular portal tract here. You in a portal tract we talk about triad because of three things. Basically, a portal vein. You can see a portal vein here, which is the largest of the structure. You have a duct here. You have a duct here. This very regular round structure lined by cuboidal cells, and there is an arteriole here. I'll show you a better arteriole again. Here, so just to show you, so here you can see a portal vein here, you can see a duct, and you can see an arteriole, because most of the times they are three in structure. That's why there is name of portal triad. You in a normal liver biopsy you can see some inflammation, few lymphocytes here and there, maybe few histiocytes also. That is all normal. That should not be diagnosed as hepatitis. Apart from this there is another portal tract. Then we have the central vein here. Yeah, you can have a central vein here. This is the central vein. This is the portal tract. This is central vein. This is the external structure, and from the central vein you can see these cords of hepatocytes. These are the cords. It's an adult liver, so you can see these single cords of hepatocytes. They are more readily or better aligned in the perivenular area rather than in the periportal area. Here you can see these are the sinusoids. Between the hepatocytes place you can see sinusoids which have Kupffer cells, endothelial cells, and Kupffer cells. And this is, most of the liver is actually hepatocytes, and 80 to 85%. Apart from that, there is portal vein, portal triad with a portal vein, with a bile duct and an arteriole, and the central vein. So this is the normal structure. Sometimes you can see mild inflammation, but that should not be interpreted as a hepatitis in a normal liver.
Can you show a bile duct once again for them?
Yes.
So bile duct should be like a pearl necklace, actually, a clean bile duct. Even this is not a very clean bile duct. So you see there is some infiltration in this bile duct as well. There is some eosinophilic material. So a nice, neat bile duct. This is a donor biopsy. I think there is some edema in the portal tract. So this is actually not a very normal, I wouldn't say it's a normal liver. This is a cadaver donor, I think. So this is what you see as like a necklace. And the arteriole you showed, can you magnify that arteriole? It's a smooth muscle. The artery that you see, can you magnify it further?
Prof, beyond this, no. I'll find a better one, Prof, for you.
So it's just a smooth muscle with some elongated cells there. So that is what an artery looks like. So when you want to diagnose chronic rejection, you should be able to identify an artery. So absence of artery is required for diagnosing chronic rejection. So even here you can see it's not a.
These are very small arteriole, Prof. Yes.
They're not very great, but doesn't matter. And the other thing that you see often is a bile duct doesn't have to be circular and like a pearl necklace. The bile ducts can be cut tangentially.
Yes.
And very often bile ducts look elongated because they've been cut tangentially. So even they can be normal as long as it's a nice row. You don't have a tangentially cut bile duct here, do you? I think this portal tract's probably got a slightly tangentially cut bile duct. Can you look at another portal tract?
Yes, Prof.
So that is not abnormal to have a tangentially cut portal tract.
This is also a regular, Prof. And arteriole is there. Here we can see a very nice arteriole, Prof. Just smooth muscles.
That's arteriole.
Cells, yes.
So this is the portal track here. Can you show that portal track? It's a,
Yes,
there's
Prof.
a preservation injury here, isn't there?
No, Prof. It's
Where
okay, Prof.
the portal tract is somewhat separated from the rest of the pattern.
Some artifacts, Prof.
Yeah, there is
Possibly
some
cutting artifact, Prof.
Yeah, people need to identify artifacts as well.
Yes.
Okay, that's fine. Let's go to the first case then. Is this the first case? It looks a normal cadaver liver.
We have a cadaver liver, Prof.
Yeah, go on. Karan, yeah, go on. Is Karan going to speak? It's better for one person to have.
Yes, sir. Yeah, I'll be speaking, sir, first.
Yeah. Go on. Start.
Just, I'm sharing my screen, sir. Yeah. So the first case, it's a 62-year-old male, NASH-related cirrhosis of liver with hepatocellular carcinoma, post-ACE, who is undergoing an DDLT. So for organ retrieval, so details of the deceased donor, 35-year-old male, he had a road traffic accident with a head injury. So the retrieval surgeon noticed that the graft appeared steatotic and hence a biopsy was done. So biopsy details will be told by Dr. Mukul.
You have to stop sharing.
Yeah.
Does Mukul have your presentation? So instead of jumping from one to the other. It's okay. Yeah, you carry on. Sorry. Does not change anything. Maybe next time we can refine things.
Prof, this is the biopsy we received, Prof. This is a cadaver donor biopsy. This was done. So it says the fat because the surgeon over there suspected that there is fatty change in the liver. This is the biopsy. This is the frozen. Actually, I'm showing you the frozen section which was received at our place. And in high power, we can go in the high power. So slightly, you can definitely there is fatty change. You can see the clear areas. The whitish areas, what you see is all fatty change, and the pink area are the normal looking hepatocytes, and this all whitish area, this is all fatty change. So we'll go in the high power. We see, if you see approximately actually we have to do the approximation. It's like eyeballing to look for what amount of fatty change is there in this biopsy. So if you see in the low power, if you see in this is a low power view of the biopsy, these are the tissue cores. You can see approximately what 25%, something around that fatty change is there in the
I would say 20-25%.
Yes, 20-25%. So
yeah. So it's only an eyeballing.
Yes, it's only an
AI in the
estimate.
future will tell us what percentage of cells are fatty.
Yes, is the surface area, the rough estimate of the surface area in a biopsy, which we eliminate, which we are going to, which we are going through the microscope, and we present that in the low power, the surface area, which is all the whitish areas, all the whitish fat. Then we go at the high power to confirm that we are dealing with the fatty change and not any artifact. So here you can see this is a frozen section. This is a frozen section done in the biopsy. Here you can see this is all is fatty change. This is macrovascular fatty change. So here is hepatocytes. Here you can see this is the fat here. This is the fat here. These all, and these are the hepatocytes. This is macrovascular because this cell is enlarged. This cell is enlarged, this cell is also enlarged, and the nucleus is pushed at the periphery. So that's how we defined a macrovascular fatty change or large droplet fatty change. A liver cell which is larger than the adjacent non-steatotic hepatocytes, and the nucleus is pushed at the periphery. So by this we confirm that this all is macrovascular fatty change or large droplet fatty change. Then there is also, we can also see these these very small vacuoles, very small vacuoles. This is small droplet fatty change. This is also a type of macrovascular fatty change, but known as small droplet fatty change. And in a cadaver biopsy, now we know. Earlier, people used to combine that this all is macrovascular, this all fatty change has to be reported in a biopsy. But now we know that if you see any injury in the biopsy, it's all because of this large droplet rather than these small droplet. These are actually because of this is also because of the injury, short-term injury of the when you harvest the liver, the injury to the liver, happen at that time, you have these small droplet fatty change here and should not be excluded, should not be included in the report. So if it comes to us in biopsy, we'll say in the rough estimate around 25%. In the low power, we can express that okay, and in other majority of the areas there is small droplet fatty change. The small droplet does not push the nucleus at the periphery, nucleus stays at the center of the hepatocytes. So this is a frozen section of a biopsy.
That's great. So this is something, how do we use these organs with the biopsy? There is certainly no inflammation here. Yes, there is no steatohepatitis here, Mukul. So this is an organ that I would use, but the feel of the liver is actually more important than even the pathology. If the liver was very stiff and hard, that would be much more difficult to use as a liver. And anything more than 50% in a cadaver organ, you wouldn't be using. But what do you expect these, what will be the effect of this? Now, when you get cell necrosis, the macrovesicular fatty cells will necrose after reperfusion. So in the postoperative period, you will have cell death. So if you did a liver biopsy on this patient 7 days post-transplant, you will see that the macrovesicular fat would have all coalesced actually, and would have been dead. So 1 month later, biopsy will actually make all the fat in this liver practically disappear. So when you use these organs, you want to reduce the cold ischemic time so that the ischemia reperfusion injury to these cells are minimized to as low as possible. So let's see what happened to the patient and look at the liver function test of this.
One more thing, Prof. I just want to say, see, these are many times superficial biopsies. So it's important to know, you can see, if you see this other core, you can see this broad fibrous septum, but this should not be diagnosed. This is part, and you can see such a large vessel here. This is a large artery here. So what we are dealing with here, this is a tangential section of a very large portal tract, which has come across when they were taking the biopsy, and this should not be taken for fibrosis. This is a normal larger portal tract, because otherwise you will say, oh, this is bridging fibrosis and should we take the liver? So this kind of fibrosis should not be misinterpreted as a fibrosis in the liver. Only the fibrosis in this area. This has some slightly mild fibrosis in this portal area. There is some few lymphocytes here, mild lymphocyte inflammation. Other portal tracts also we can see there is some very mild sprinkling of lymphocytes. This is the duct, looks okay. This is the vein, artery is difficult. It's frozen section, sometimes can be difficult. Still, this is a very, very good section, and this should be excluded. So if the final report would be around 20-25% of large droplet fatty change and minimal to mild portal fibrosis, very mild inflammation, no steatohepatitis. There's no ballooning as such in the or lobular activity in the biopsy.
I have to actually remind people, this section almost looks like paraffin section. Very often in frozen section, you will not get this good a biopsy actually. So they are much more difficult to interpret, the frozen section. And also the thickness of the biopsy is much, much thicker. So there is another thing that you need to take into consideration. If you go higher, Mukul, can you go higher? In a frozen section, actually, you wouldn't be able to see the hepatocytes so separated like in a paraffin section, because a paraffin section is so thin, you can see a single layer of sheet of cells, whereas in a frozen section, it's not necessarily a single layer of cells. There are multiple layers of cells, one on top of each other. So they are much more difficult to actually individually see and assess.
Yes.
Yeah,
it can be at times, because sometimes we see biopsies from outside or images will come to comment, and it's very, if the frozens are not very well cut. These are all late night biopsies, but still I think definitely I definitely congratulate my technicians actually who do such kind of job. And I'll show you paraffin. There is also paraffin of this which we got. So just to show you, I can't move. It's stuck. Sorry.
can you get out and come back?
No, I think Karan should come. I'll come back and then I'll do. Prof.
Okay, Karan.
Yes.
See how this patient is done.
Yes, Prof. So we went ahead with the transplantation for this patient. So the graft weight was 1,400 grams and the GRW 1.6. The cold ischemia time was 490 minutes. Uneventful reperfusion.
Can you move to the next slide? Move to the next slide.
Is it gone, sir?
No.
No, it's only histopathology is this slide.
Make it slideshow, and then you'll be able to move.
I'll just do it again, sir.
Mukul, you need a much more powerful.
Is this better, sir? Are you able to see?
Yeah, you can see now.
Yeah. So this is the the graft weight was 1,400 grams, and the cold ischemia time is around 490 minutes. Uneven full reperfusion. So this is the post-op course, where on the post-op day 1, the bilirubin is 8.2, and the enzymes AST is 5,676, and ALT is 1,175, with an INR of 2.5. On post-op day 2, the bilirubin is 9.46, and if you observe, the AST has drastically come down to 2,553, but the ALT is lagging behind, and it is 1,000. The gamma GT is 80, and steroids are going on for the patient. Sequentially, as days pass by, the bilirubin is increasing post-op day 3, but the enzymes are coming down with ALT lagging behind. The INR remains around 2.3 and 2.5. So on post-op day 7, the bilirubin is 10.9, with an enzyme significantly coming down to AST of 77 and ALT of 203. The TAC level is 3.8, and there is mild AKI. INR is 2.3 on the post-op day 7. We still wait and we give it time because the enzymes are coming down and the patient otherwise is doing clinically well. The bilirubin on post-op day 10 reaches a peak of 16.14 with enzyme AST coming down to 38 and ALT to 36. On post-op day 14, then the bilirubin starts dropping slightly, and from 16 it has come down to 13.9, and the enzymes also remain on the lower side. The INR has also started dropping, and it is 1.8 on post-op day 14.
So I think everything went well. I think the patient was discharged on day 20, and day 30 liver function tests are completely normal. Now, this is something you would expect when you use a liver like this, and you shouldn't panic on the first day. Actually, when you look at the first day AST, and I'll talk to you about the difference between the AST and ALT and interpreting how it is falling. You need to understand that AST's half-life is less than 24 hours. It's about 18 to 20 hours is the AST's half-life. ALT's half-life is 3 days. So ALT will never halve every day, whereas AST will halve every day. Now, the other thing that you need to remember is for AST to halve every day, you shouldn't have an ongoing injury to the liver. So when you see that it is halved, so there is no more ongoing injury to the liver. Whatever injury happened at the time of reperfusion or during the first day. But injuries will happen to the liver if a patient becomes very sick as a result of you putting a bad liver in. So if you put a bad liver in and you get a severe reperfusion injury and the patient goes on high inotropes for the first 24 hours, you will not expect a fall in AST from 5,000 to 2,500 because there is an ongoing injury to the patient. Then the AST will remain high and the patients get sick because there is an ongoing injury. So here it's very clear that this patient is going to do well. On the day 2 enzymes, you can very clearly say that this patient is going to do well because the injury was just at the time of the operation. The second day, there is no ongoing injury. And the bilirubin going up, again, is a standard thing. So this is like an acute viral hepatitis. So the bilirubin always lags behind the enzymes. So the first rise is actually an injury, and the injury producing the high enzymes. And then the bilirubin is a little later phenomenon, which will fall with time. So this is actually a perfectly normal course for a liver which is suboptimal, which actually has a 30% steatosis with necrosis of probably around 20-30% of its hepatocytes, and the liver is recovered completely back to normal. So that would be a normal course that you would see, and not to panic when you see results like that. Okay, so let's move on.
Yes, Prof. So, yeah. So we'll
Another donor, Prof. Living donor.
Okay.
Yeah, Prof, we'll go on to the next case, Prof. So this is a 19 years old male who is from Yemen. He is a prospective living-related donor for his uncle who has autoimmune-related decompensated cirrhosis of liver. He per se has no comorbidities, no significant past history, to worry about. And during fitness assessment, he is fit in all aspects and very compatible liver anatomy. So hence we decided to go ahead with a robotic donor hepatectomy. So this is a CT, just for contrast CT of the donor. So he was posted for a robotic donor hepatectomy, and when the camera scope was inserted, the liver appeared to have tiny white spots on its surface. Immediately, a frozen section was done. We showed some granulomatous changes, and hence we did not proceed with donor hepatectomy. The biopsy now will be discussed by Mukul sir, and this is the image which was seen on the camera scope. You can see these white spots. I'm stopping sharing, sir. Mukul sir, over to you.
So this is the frozen section here. You can see this is again, this is, I'm telling, this is the frozen here. This is not the paraffin, and this was received at us. They send us a part of that from whitish area nodules which you saw on the liver, the subcapsular. This is the liver. This is the liver capsule here. This is the inferior edge of that biopsy. And here you can see that there are multiple granulomas in the liver. Again, at the high power, there are these granulomas here with some inflammatory around these are histiocytes, epithelioid histiocytes here. There's some fibrosis, and surrounding it also there is some inflammation. Here also you can see this is a little more better form granuloma. This is again a granuloma. These are all histiocytes. These are all epithelioid with slipper shaped nucleus. These are all epithelioid histiocytes here, and there is surrounding, you see inflammation. We can see inflammation, but inflammation, if you see around, there are a lot of these cells with very pink cytoplasm and bilobation. These all cells mixed with lymphocytes and histiocytes. These are all eosinophils. So this is, with this, there are granulomas and with eosinophils, a patient from Yemen. So we suspected, are we dealing with a parasite infection? So we took another serial section again in the frozen just to see if we could see a parasite, but we couldn't see a parasite. So we suggested we are dealing with a granulomatous lesion in the liver with eosinophils, because there are eosinophils in the periphery of these granulomas. These eosinophilic collection of microabscesses kind suspected parasitic infection was the suspected etiology, and waited for the paraffin section. Then this is the paraffin section of the same liver, and you can see. Prof, this is the granuloma one.
Yeah, I know. Yeah.
Frozen. I showed Prof first.
Yeah, I saw that.
Sure. Okay. And Prof, then this is the paraffin. This is the frozen which we showed, in which we couldn't identify any parasite as such or any necrosis in the granuloma. They were granulomas at various stages. However, in the paraffin section, which came the next day, just to show you, we identified the eggshell. So this is a granuloma. Here you can see a giant cell here, and you can see these brownish structure. You can see this brownish structure here. This is the eggshell. So with this, considering the patient is from Yemen, with the eggshell, even if we don't see a typical egg of schistosoma, but with these characteristic features and the schistosoma, which is endemic in all zones of the Yemen, we consider the diagnosis of hepatic schistosomiasis.
Yeah, I mean, we abandoned it because we needed to exclude tuberculosis. Here there is not much of it. What showed, I mean, we would have thought this is a TB typically, wouldn't you? Those nodules on the surface of the liver, but there were no peritoneal nodules. Everything was in the liver only. So initially we thought it could be TB, but the biopsy clearly showed eosinophils. Can you go back to the frozen section and here show us eosinophils? I want people to be able to identify eosinophils, because it's, I mean, for the pathologist, it's such a basic thing. So you look at a cell.
Yes, Prof.
Then
you can, these all orange cells, Prof.
Yeah, it's pink in color is one thing.
Yes.
But the nucleus is segmented. Can you show that the nucleus is not just a straight round nucleus? It's like
Prof, you can see bilobes. Many of them we can see bilobes.
Yeah, that one, the last one you saw. So it's a single cell with nucleus.
Yes.
Which is really 2 or 3 nodular nucleus. So that's how you identify really polymorphs and differentiate them from lymphocytes and eosinophils. So clearly here, eosinophilic granuloma from a person from Yemen, you have to think of parasitic infection. And this patient should be treated, and then after treatment, obviously, in about 2 to 3 weeks, should be fit to donate once again. This was last week, so we have not transplanted this patient yet. Okay. Thank you. So pathology makes quick decisions. You don't have to wait. I mean, we are looking for TB as well. I don't think TB is the problem here.
Karan, before you move on, I would want to request people who are attending, if they have any questions, they can post those questions in the chat box. I can see a few senior pathologists here, Dr. Dugal, Dr. Arora. If you want to make any comments, please go ahead.
Sorry, I don't know if I should be talking in front of senior pathologists. Do pardon me if I'm making some basic mistakes in pathology, because I'm the link between the pathologists and the clinicians. So I'm talking on behalf of the clinicians, I'm afraid, not for the pathologists.
Yes.
Yeah.
So the
I
next
don't
case.
want them to be offended from what I'm saying. Okay.
Okay. The next case will be a 65-year-old male who underwent living donor liver transplantation for NASH-related cirrhosis, child status, HCC, which was downstage by TACE. So it was a right lobe graft with a graft weight ratio of 0.89 and 2 ducts in a cup. He had an uneventful postoperative period and had a good recovery. Discharged on third week postoperatively. And he was on regular follow-up to our post-transplant clinic. Fifth week follow-up showed near normal LFTs with AST of 19, gamma GT of 75, and attack levels of 7.3 on tacrolimus doses of 1 and 1.5. He was also on mofetil 500 BD and tapering steroids of 7.5 milligram. But when he came to 6 weeks review, he was asymptomatic, but there was elevation of the LFTs with a bilirubin of 2.8 and a direct component of 1.9. AST 553, ALT of 680, alphas gamma GT of 268 and 436, and his tacrolimus levels were 9.2. After ruling out infections in other viral serologies and imaging which showed a normal graft with normal portal venous and hepatic Doppler, we went ahead and did a liver biopsy. Over to you, Mukul sir.
So it's unusual to get a rejection at this point, actually. So anyway, we did a biopsy.
Yes.
Because all virology have been negative.
So here is the biopsy, Prof. This is the biopsy core. We can see this is the single core. It's a good core, 1.5 centimeter biopsy. And let's see in the if you see in the low power, you can see definitely that there are blue areas in the low power. You can see these blue areas, which is possibly portal tracts with inflammation, and these are normal pinkish areas. So there is a difference. You can see that there are blue areas and pink areas throughout the biopsy. So suggesting that in the low power that we are dealing with inflammation in the biopsy. There is quite a bit of inflammation in the biopsy. Let's see this score. This in the higher power. So what you see here, we saw the duct, how regular it was arranged. Here what you see here, we are seeing a lot of inflammation. A lot of inflammation is in this large portal tract. We can see a lot of inflammation in this portal tract, and inflammation is mixed. You can again see lymphocytes. You can see eosinophils. Can you see this is bilobe eosinophils, very well actually seen here in this biopsy. Multiple eosinophils are there. Lymphocytes, there are histiocytes, also activated lymphocytes. Those all are there. This is the duct. You can see this is white.
Eosinophils are quite common in rejection. So I don't want people to immediately think about parasitic disease, because we just talked about parasitic disease.
Or drug, yes, Prof.
Yes, yeah.
So mixed inflammation, actually it leads you to, when you see mixed inflammation with eosinophils, especially in an early post-transplant biopsy, you know that you are dealing with a rejection. So that is actually because in other hepatitis or something, the inflammation is not so mixed. You see mostly lymphocytes. So this is a clue for us. You can see a duct here. And again,
I want to show them how the duct is cut tangentially cut duct. This is, you saw a circular, like a pearl necklace before, but a tangentially cut duct should not be confused to be abnormal. Okay.
Here again, a duct is here, Prof. This is a nice duct we can see. Here are eosinophils, and you can see the duct. There is definitely the lumen is this elliptical. It's not really rounded, and you can see infiltration by these lymphocytes. See, this is the duct. Can you see the duct? Can you see the duct? And this is the lymphocyte. So we are seeing inflammation, which is mixed inflammation. There is quite a bit of this is a large portal tract. This is a very large portal tract in which you are seeing a lot of inflammation. The ducts are showing infiltration by lymphocytes. Even eosinophils also are infiltrating in other areas. This is a portal vein. You can see a portal vein. So you can also see subendothelial inflammation in the portal vein. There's the endothelial cells in the portal vein, and there is this infiltration of this mixed inflammation, lymphocyte, histiocytes, eosinophils also in the subendothelial space, which is lifting the endothelium here. See how it is well arranged here. If you see a portal vein and see here, they are activated, they are enlarged, the endothelials are little enlarged, and you can see inflammation just below. And if more severe inflammation, you can even see disruption. So we are seeing three features. So characteristic, this is a post-transplant biopsy, early biopsy because it's less than 3 months. In a biopsy, you are seeing the typical three signs of the Sonova triad, which is there is inflammation in the portal area, there is ductal injury, lymphocytic, there is infiltration of the duct by lymphocytes, and you can see portal vein endothelitis. So all these features consistent with the biopsy, with the diagnosis of rejection.
Can you show another portal tract? Because it's
Yes,
not
Prof.
often people will get a portal tract like that.
Yes.
Diagnosed
Yes.
section.
Yes.
So let's see the smaller portal tract. So
Yes, Prof. This is okay.
So
lot of information
the
actually.
3 points that you remember, you can also remember expansion of the portal tract. So
Yes.
you saw portal tracts before. I've only got 3 structures in it: the vein, the artery, and a little bit of hyalinized tissue. But here you see that the portal tract is fully infiltrated and it's expanded actually.
Yes.
And you see the eosinophils, you see the mononuclear cells.
Yes.
Here you see a beautiful arteriole. Can you show them
Yes.
the arteriole?
Yes. Yes. Yes.
There is the arteriole, which is just a smooth muscle with
Yes.
with the lining cells. That is an arteriole, but the arteriole is undamaged, whereas you see most of the bile ducts in the portal tracts are damaged.
Yes. Yeah, actually very difficult to identify. When there is so much inflammation, it will overrun. The bile ducts will be overrun by the inflammatory cells. So it's very so. But this is very, very distorted and injured bile duct here. This is also a bile duct. You can also see some probably polymorphs also here. So you can see some polymorphs also in a severe rejection. This is also a bile duct here.
That
Human
one
is
that
very
he's showing is, you have to imagine the bile duct. In fact,
yes.
anyone can imagine the bile duct, but
Yes.
those are really biliary epithelial cells. That's a bile duct epithelium.
Yes.
Surrounded by, the rest of them are really scattered everywhere.
Yes.
And in the middle of all of this, there will be many bile ducts which are damaged and swallowed up by the inflammation. So this is really what? Severe rejection?
Severe rejection, Prof. Severe rejection. Apart from the portal area, Prof, if you go to the adjacent to the portal area, if you see this adjacent, it will not show much of inflammation. So this is largely, you can see some sprinkling of lymphocytes, but we don't see much inflammation. But again, if we go at the central vein area, because we are dealing with the severe, possibly severe rejection here, we'll go to a central area, and I'll show you that. So first of all the portal tracts are showing inflammation, multiple portal tracts are, and this is the central area. This is the central vein, which was in the, this is the central vein here, and you can see inflammation and cell dropout. So there is also necrosis around central vein. So again, signs of severe rejection. So there is involvement of the portal area with lot of inflammation, with all features of rejection, and also the central area, the hepatocytes is largely unremarkable. But as we reach the centrizonal area or around central vein, you can see central endothelitis or perivenulitis or central lobar necroinflammation. And there is also necrosis here. There is dropout of the hepatocytes. Ideally, throughout the central vein, we should see hepatocytes, but in this area, you can see hepatocytes, but in this area, you don't see. So this is all showing necrosis. So we are dealing with a severe rejection with involvement of the portal as well as central areas.
Can we take the opportunity here to show them the lobular structure and how, like a cartwheel, it is going, and the cells are single cell thick? Can you
yes. In this probably possibly because there is an injury of the cell. So there is, and also there is central lobular infiltration.
It's a beautiful demonstration of a cartwheel where it's all radiating from
radiating out. Yes, radiating out.
Very nicely arranged. They are single cell thick with
single cell thick
in between. Because later on you will see how when they get regeneration, they become thickened.
They become thickened.
Yeah. So this is a nice demonstration of that.
So this was diagnosed as severe rejection by us. We can do the global assessment, mild, moderate, severe, like, and also we can do the RAI score to give you this. This will go into RAI 7 or 8. So there is severe rejection. Then biopsy was made. A provisional diagnosis was given.
Okay. You're going to tell us what you did to this patient?
Yes, sir.
Yes, sir. So with the biopsy finding of a severe rejection, we went ahead and pulsed with steroids, methylprednisolone 1 gram per day for 3 days, escalated the MMF to 1 gram twice a day, and after 3 days of methylprednisolone pulsing, he was discharged with tacrolimus and 30 milligram of oral prednisolone and MMF 1 gram twice a day. And subsequently, 7th week, within a week's time of post pulsing, his LFTs came down. His AST has come down to 52 from 553, ALT to 60 from 680, alphos and gamma GT to 200 and 372 with adequate TAC levels of 10.2. And subsequently, third month, the LFTs became near normal with a good tacrolimus levels. And he's on regular follow-up with us. And this is the latest follow-up, 2 years post-transplant. 3 months back, he visited us, and he has a bilirubin of 0.76, AST and gamma GT of 14 and 48, with a tacrolimus level of 4.5. And steroids has been tapered and stopped. He's on double immunosuppression, tacrolimus, and MMF 250 twice a day.
Thank you. That's good. That's a good outcome. Can we move on to the next one?
Yes,
Prof,
please.
before we move on to the
Any
next,
questions?
can
You
we
have
have a few questions
Yeah,
which are there in
sure.
the chat box?
Yeah, please do ask
So,
them.
yeah, so the first question is, what's the macrosteatosis cutoff in living liver donation?
Guys, I think you should answer that question. For me, it's 20% for a right lobe. For a left lateral segment, you could do 30, whatever you want. But I've not even done 20%. I would worry about more than 10% in a right lobe donation.
Right, I would agree to that. We stick to 10% in our practice for right lobes. Second is, what is the clinical relevance of microvesicular steatosis in liver biopsy?
Go on, Mukul.
So okay, so microvascular stenosis actually it's used very commonly everywhere, but microvascular stenosis is extremely rare in liver biopsies. Actually, you see what is actually the what we talk about in donor biopsies of microvascular is actually the small droplet fatty change. Microvascular there is very foamy appearance to the cytoplasm, and it occurs in fatty oxidation defects in pediatric with metabolic liver disease, and you can also see some foamy change in some severe NASH and also in alcoholics. So that is not so common. What we see usually, and it is actually, if you have that kind of injury in the liver, then you know that there is a severe injury to the liver. What we see as small droplet is now considered in donor biopsies, especially in cadaveric donor, when you want to count how much of, when you want to know how much fat is there, that small droplet is not counted. Only the large droplet fatty change, which is defined as a large vacuole displacing the nucleus to the periphery and enlarging the hepatocytes. That is the definition, and that is actually considered for all the practical purposes. A small droplet fatty change, what you see in a cadaver donor biopsies, is actually because of the injury. It's very short-lived. If you repeat a biopsy after 2 days, you are not going to see fatty macrovascular. You can still see up to 2 weeks or something, but that small droplet actually goes very fast, and it does not cause much injury. There is some reports that if you see small droplet fatty change, can lead to some aggravated rejection in those biopsies. I don't know, there were some studies which show, but they also did well. They treated the rejection. It has been, if you see lot of small droplets, they have said you can see there is more rejection in those patients. But apart from that, I don't think much is there. It's usually considered harmless.
Can I just add one statement about microvesicular? So isolated severe microvesicular steatosis is an indication of mitochondrial injury, actually. So where your lipid peroxidation is affected. And so that you typically see in patients with yellow phosphorus poisoning, acute fatty liver pregnancy, Wilson's disease, where the fat is, confined to the definition, what you just said. Unlike the macrovesicular steatosis, which is totally a different pathogenesis. Isolated microvesicular steatosis is a completely different phenomenon, and it's actually in somebody, say for example, somebody with fatty liver pregnancy, yellow phosphorus poisoning, it's actually not a good sign to have.
I just want to ask,
and just one more thing. Actually, one more thing I want to say: microvascular, the microvascular, the defined foamy cytoplasm in the micro, you cannot count those droplets. Small droplet fatty change, which are very small also, which can be less than size of the nucleus, you can count them. So that is also, if you are able to count the droplets in hepatocyte, it is not microvascular. Microvascular is extremely difficult to count. It is diffuse. The cytoplasm looks very foamy. You can't count those droplets. So that is also one thing in a biopsy, if somebody is seeing how to really interpret what we are seeing.
Dr. Sagan.
I just want to ask a very basic question. I've been, actually trying to understand this for the last, 2 decades. You say the fat percentage is the most important part, 10%, 20%, 15%. Surgeons, they really take it very important, from their own perspective. So have we evolved with a better way of understanding what is the percentage of fat in a given biopsy? Is it still in, or you are subject to assessment, but you may do something, your other colleague may have a different understanding, you're training, somebody who's joined new. Is there some sort of AI-based model where we can have a objective evidence of fat? So that is a thing which I am still a bit not very clear. And maybe if you can answer that part, would be very nice.
Yes, just to tell you about this, actually, fatty chain, there were no guidelines. I think few years back, there were no such guidelines, and there were several. If you see the various US centers or European centers, they all, somebody defined macrovascular with Brunt criteria, somebody with other large cells. So there were no, but I think 2020 paper, if you see the BAM guidelines in 2022 in hepatology, that they actually defined, and it was Professor Demetrius was there as one of the senior authors, who and other senior three hepatopathologists, they look at the biopsies and what they define, that what actually, because there, I tell you, the if you see that paper, the variation, if somebody has reported like 10%, other center has reported like 70%. So that is the sum count. Yes. This
Problem is,
is
Sanjeev,
it's very subjective. Yes,
it doesn't matter to be so accurate. So if somebody calls it 20% and the other calls 30%,
yeah, Prof, does not matter.
I don't think it matters. I think beyond. In fact, the surgeon who's retrieving is probably the best judge.
Yes.
You can have a very fatty looking liver, but it's absolutely soft. It may be usable. You'll have a fatty looking liver, which is really hard to feel. It's not usable, irrespective of the histology. The marker for histology is beyond 50% is suspect.
Yes.
Understand? So the differentiating between 5%, 10%, 15%, 20%, it may be important for a donor, for instance, whether it is 10% or 20%. But I'm talking about the living donor. I don't think in the DDLT setting, you need to be so accurate. I think that's why he says, look at the low power magnification, and then you make a guess what percentage it is.
It's just eyeballing.
You can't do a high power magnification. So you have to look at the whole strip and see, oh, I think this is 20%, this is 30%. That's all it is. I don't think we need to know exactly how many percent it is.
Yes. Prof, you can do imagine. I think there are some AI models.
I mean, today, I think with AI, you might get a more accurate. The AI would be able to count the total number of cells in the field and tell you how many.
Yes, and the white cells. So it can differentiate the white cells from the pink cells.
That will come. I'm sure it will come very quickly as well.
Prof, what you said is extremely important, Prof, that actually, if you say less than, I don't know, 50%, but less than 30, if somebody is saying 50% and 30%, okay, definitely surgeon will think. But somebody is saying 20%, 25, this is all very subjective. And more you see biopsies, and I tell you, even we see so many frozens and hair from it, but sometimes it's extremely difficult. How the biopsy is done, how the biopsy is brought to the lab. Was it in immersive solution, or somebody has put in saline for 2 hours and bought it up from somewhere? It has so much artifacts. It's become so difficult for sometimes for actually to comment on the exact fat. So we make a guess. It's a guesstimate only. It's not, but yeah, but we more and more, you see, you understand overall, okay, this must be around 20-25%. So I don't give just 20%. I say 25 to 30%. Possibly I'm seeing 30 to 40%, because you never know. It can be 30 or it can be near 40. So like that. So. And then I think surgeons call to take the liver or not. Yes.
We need to move on, guys. If you want all the cases or,
the next question is, if we get only one of those 3 features of rejection, what will be the diagnosis?
No, that's how severity is done. You have to assess how much is there. So it will be a mild rejection. If it's a rejection like infiltrate, it's in some of the portal tracts. Rejection like infiltrate, mixed inflammation. You have lymphocytes, few eosinophils, maybe some injury. You say mild. So that is all. That is how you grade a liver. So it will be, you're not going to treat a mild rejection. You will just optimize the immunosuppression. Moderate and severe, you are going to treat. So that is all grading. That's why you need to do grading.
It's not.
So global assessment is good.
It's not as if you're going to have intense inflammation and a perfectly normal looking bile duct throughout.
Yes. It's not like that.
It's the degree is determined by how much inflammation there is, whether there is a duct damage or not. I mean, this one, actually, Mukul said there is endotheliitis, but actually there wasn't a lot of endotheliitis in this biopsy, even though it's severe. I didn't want to say against what Mukul was trying to convince you about endotheliitis. Yes, there was infiltration under the endothelium, but the endothelium was not lifted up. A classical endotheliitis, the endothelium is actually lifted off. So I don't think it matters. I mean, if you don't see much of the findings, and if they will say if your LFTs are abnormal, it's a mild rejection. You know, the enzymes are only 120, 140 AST. They also need your clinical input to say how bad things are.
Yes. And Prof, I think this was more relevant when we were dealing with Hep C recurrence. I think now it's much more, because Hep C was extremely difficult at times, actually.
Those days were really bad, really.
Yes, very difficult at times. But now I think not much issue.
And treating rejection, which is recurrence of hepatitis C, would have been a disaster. So, and also Hep C associated with rejection. Can we move on?
Yeah, I'm going to take a couple more questions before we move on. And then there are a lot of questions that are popping up in the chat box. I think people are a lot more interested in asking questions. So sorry to stop you there. How can you differentiate macrovesicular steatosis and ice artifact and D-atom separation between the cells?
Come on, guys. I think this is a pathologist. I think they will learn it. Artifacts are cracks in the big cracks. They are not steatoses. We won't go into that. Maybe in another day.
So
ask your pathologist is the answer.
Yeah. Are there any features on the biopsy in ACR which can help in predicting the response to pulse steroids?
Mukul, do you want to say that? I would simply say inflammation alone is what I would look to see if there has been a response.
If I didn't get it, there is.
How do you, if you do a biopsy after treating a rejection, how can you tell that the patient has responded to treatment?
No, nobody repeats a biopsy. And
yeah, so absolutely right. So you would repeat a biopsy only when there is no response to treatment.
Yes.
No. The question is, can you predict on the biopsy that this patient will respond to steroids?
A typical rejection should respond. I think early rejection respond. So most of them will respond. Majority of them will respond with inflammation. I'm not getting it. Are we talking about late rejections?
I think they're trying to ask what would be like any histological indicator which will predict response or anything to predict otherwise. So probably zone 3 change or zone 3 necrosis is more likely to cause steroid resistance, if that is what the clinician is trying to figure out.
I think these are very previous, these are very old studies actually. When we talk about that zone injury, we see a lot of injuries in the zone 3, severe rejections, sometimes whatever 20% rejection we see, and I don't think there is much. I think there is this importance actually lies early and late. So if you are dealing with 3 or 6 months rejection and you see some kind of central lobular injury, inflammation, late injury matters actually. If you're seeing late, because there is something probably there is a case there in which I'll show you there is no inflammation, but there is a lot of necrosis. Yeah, that may go down as
yes. So probably what they're trying to ask is what may not be.
You have to see at what time biopsy is done. What are the other findings? So I think holistic approach. At what time of a patient biopsy is done? Is it early, late? Many things matter sometimes.
No, the point here is if you are making a diagnosis of histological rejection, you have to try treating. If you are trying to say, oh, this is going to be histologically unresponsive rejection, I don't think there is any situation where one can say this is a histologically unresponsive rejection and therefore it's a waste of time escalating immunosuppression. I don't think that situation would arise. You would want to treat every histologically proven rejection. Unresponsiveness of a rejection is based on clinical judgment. After treatment only, you can say it's unresponsive. I don't think the pathology is going to say this is such a severe rejection that it's a waste of time treating the rejection. I don't think that's possible.
Prof, I think
the other thing is saying that when there is a zone 3 necrosis, maybe they're less likely to respond. Maybe it just represents a severity of injury, really. And maybe those patients may not do so well with treatment. That may be the reason why people may be coming up with that sort of criteria that if there is necrosis in zone 3, it may not respond well to treatment. But that itself, necrosis in zone 3 itself indicates it's a very severe form. Okay, let's move on.
Going on to the next case, sir. Yeah. So, a 51-year-old male NASH-treated end-stage liver disease with a MELD of 24, acute kidney injury, ascites with a recent episode of spontaneous bacterial peritonitis. When culture grew an XDR Klebsiella, treated with appropriate antibiotics for 2 weeks and then taken up for a living donor liver transplantation. The GRWR was 1.28, reduction in a cuff, extubated the very next day of transplant, shifted to the ward on post-op day 5, had a smooth course. Only issue was a high drain output, which was managed medically. LFTs were gradually settling and ultrasound Doppler was normal. On post-op day 8, he had a sudden episode of hypoglycemia through a generalized tonic-clonic seizure, was shifted to the ICU and intubated. So these were the LFTs of this patient. So on post-op day 1, the bilirubin was 3.76 with an enzymes of 109 and 82. On post-op day 5, the bilirubin was coming down to 2.66, enzymes also settling to 46 and 54, AST and ALT. On post-op day 8, when this episode happened, the bilirubin increased to 4.48, the enzymes also slightly increased. Ultrasound showed a septated hemorrhagic collection in the cut surface area of the liver. On quantification, it was around 250 cc. A patient was intubated, so at the same time a bronchoalveolar lavage was also done, which grew Burkhold area as the patient had recent episode of sepsis, so we wanted to rule out infections. Cut surface collection was drained and it drained, cell count was 695 cells with 96% neutrophils. And the culture from the drain drew enterococcus. So antibiotics were escalated and meanwhile the graft took a hit. So on post-op day 9, the bilirubin went up to 3.54 and the enzymes 43 and 51 with a high drain output. TAC level was around 11 at that point of time. Post-op day 15, the bilirubin went up to 10.2 and enzymes, if you see AST was 40 and ALT of 61. The enzyme elevation was not much significant. The gamma GT was 232. TAC level was 5 and steroids were tapered to 17.5. On day 20, though with appropriate antibiotics, the bilirubin kept increasing. It went to 12.24 and the AST of 175, ALT of 159 and gamma GT of 539 with a TAC level of 6.1 and steroids of 17.5. So at this time, we decided to go in for a liver biopsy. Mukul sir.
Yeah. So this is the biopsy course we received. You can see this biopsy here, and okay, there's some rolling over of the tissue. So here,
Dr.
what we
Mukul,
see.
can you change the color of your pointer? I mean, is that possible?
Oh, just how to show it, how to check.
That's fine.
Okay.
All right.
Okay, it's okay. So this is the biopsy tissue. You can see again there are some blue areas here, some yellowish brownish areas here also, and this is the pinkish areas. So we go in this expanded blue looking areas, and what we see here, you see a lot of inflammation, but this inflammation is different what we saw in rejection. So here what we are seeing, first of all, there is expansion of the portal area. This is very expanded portal tract. There are ductules at the margin. See, this is the limiting plate. This is the portal limiting plate here around the around the portal tract. So, if you just go through it, and these are the ducts at the margins, multiple ductules you can see, and they have these large bile static, these bile plugs. Throughout these ducts, you can see they are dilated and they have these bile plugs. If you look at it, inflammation, now what you see, inflammation, it's mostly polymorphs. So these are polymorphs. You can see multiple polymorphs. They are multilobated. These all are, you can see some lymphocytes also, but you can see multiple polymorphs throughout. Here again you can see. You can also see polymorphs infiltrating the duct wall, these ductules, these marginal ductules, which are dilated. You can see polymorphs infiltrating here. Here also you can see in the wall. Can you see a polymorph here? So there is polymorph infiltration. So overall, we are seeing expanded portal tract with inflammation, bile ductular proliferation at the periphery, these marginal ductules which are dilated and have these biliary casts throughout. They have a lot of these bile thrombi, and inflammation which is mixed and also infiltrating the ductules. So with this is classically known as cholangitis lenta, and this is because of the septicemia in the septicemic injury in the patient.
Okay. So what did we do?
So after the biopsy, antibiotics were escalated, and ceftazidime, avibactam, aspirin, and doxycycline. So these type of antibiotics were added, and gradually, if you see, the bilirubin from 12.2 on post-op day 20, on post-op day 25, it dropped down to 6.6 with the enzymes of 150 and 152. The gamma GT went up to 1024. We continued tacrolimus at 7 and steroids at 12.5 as the graph was improving. Then post-op day 30, bilirubin was 6 and the enzymes also 176 and 138, not much of an elevation. At this point of time, the patient was discharged with IV antibiotics from the ward. One follow-up every 3 days, and if you see around the post-op day 50, the patient's bilirubin dropped down to 1, enzymes 43 and 52, and a gamma GT of 175. TAC level was 7.5 and steroids of 2.5, and then tapered and stopped.
Can you go back to the pre-treatment enzymes, the liver?
Yes, Prof. The
Yeah.
enzymes.
So this is probably the lesson to learn is
Yes.
on post-operative day 20, the bilirubin goes up to 12, the enzymes, ASTs jump from 40 to 175, 159. The mistake here would be to treat this like rejection without a biopsy. You would make the patient much worse if you actually treated this as rejection. That is why I think it is so important in difficult situations like this to get a biopsy to know what is going on rather than empirically try a treatment with steroids to see what happens. And then when the steroid doesn't help, treat it as a sepsis or infection. So that's the point that I wanted to make with this case. Just get the information that you can get, all the information before you can hit them with steroids, thinking this is possibly rejection, because it is possible for this to be rejection too. If you see on day 15, the tacrolimus level is a little bit low and 6.1, and bilirubin has gone up and the enzymes have gone up. Thank you. I think we move on. Move on. Is there any questions about this? If you want to ask Abhidip, you're watching the question.
Yeah, not in terms of this. There are a few other questions. Maybe towards the end we'll take that. It is related to the previous cases.
Okay.
Now we move on to the next case, which is a 51-year-old male who underwent living liver transplantation for ethanol-related end-stage liver disease in July 2018 elsewhere. It was a right lobe graft with single duct-to-duct anastomosis. And as per the records, the immediate post-operative period was uneventful. But around 4 to 5 months post-operatively, there was progressively increasing liver function tests. And MRCP, which was done at the time, showed biliary anastomotic stricture. RPST, there was biliary duct dilatation. So an ERCP stenting was attempted there, which was failed. Subsequently, he was placed on PTBD and external drain to the right system. Over the course of next 1.5 years, he had repeated tube blocks, repositioning and tube changes with multiple cholangitic episodes. In between, they had tried to internalize, which was also failed. And nearly after 2 years post liver transplantation, he came to us for further management. I have just projected the lastly available 2 LFTs, which was there before he came to our center. So we can see that around 2 months, 3 months before coming to our center, his bilirubin was high, he was cholestatic, and AST ALT was also high, and the gamma GT was 278 and 342 with a very high tacrolimus levels. And he landed to our RIMC in November 2020 with a frank cholangitic episode. His bilirubin was 32.8 with a direct component of 26.5, febrile with chills and rigors, and his tube was blocked. And with a gamma GT level of 427, alkaline phosphatase of 234, and a tacrolimus level of 16.2. He was at that time 2 milligrams.
You're on the wrong slide. Is it on the right? Oh yeah, sorry.
Yes, right side. I have just put comparison. I have just taken here.
Yeah.
In this juncture, we stabilized him. Tube exchange was done to the right system, which drained thick pus. We upsized the tube, and then appropriate culture sensitivity positive antibiotics were added. And the same sitting RASD was also dilated, And a tube was done to the right anterior duct system also, and immunosuppression modification was done. He was on low dose steroids, which was also stopped. And subsequently, he was monitored daily in the ward, and the PTBD outputs both from the right anterior and posterior sectoral ducts were adequate, and immunosuppression was closely monitored. And about 2 weeks post these managements, the enzymes levels were significantly reduced, halved. The GGT, gamma GT levels came down to 298 from 427, and the AST ALT remained around 87 and 48 with a tacrolimus level of 6.5. He was on only single immunosuppression at that time. So the plan was to go ahead with the hepatico-jejunostomy once when the liver things came. But before going,
I think that let me just put a thought process into this. I mean, you might wonder why would you need a liver biopsy? Here we have very clearly got a patient with biliary obstruction, and we manage the obstruction over a period of time. But very often, I'm somebody who's very keen. If a patient has been suffering from 2 years or 1 year with biliary strictures and repeated admissions with cholangitis, I think it's better to go for hepatogenostomy, even though many people are very afraid of doing that operation. But what you can do with all of this is, if these patients have been managed, it's very difficult to manage immunosuppression on somebody who's got a biliary problem where the enzymes are very abnormal. And a lot of them really get very high immunosuppression. And I've also seen many people who withdraw immunosuppression in some of these patients when they are septic. And you get a combination of chronic rejection and a biliary obstruction, and you go and repair the biliary obstruction, they don't get better because the biopsy shows that there is a chronic rejection. So I think it is very important to understand what we are dealing with a liver biopsy before you can actually do intervention, or also to find out why the liver function is not improving if you are actually draining the entire biliary system, because it's important to know, and it's dangerous to escalate immunosuppression in these patients without understanding if there is anything treatable there. So that's the reason why I would do a liver biopsy in these patients. Obviously, if it's a biliary, you're going to see exactly a similar picture like last time, CAS and long-standing biliary strictures. You will see. Oh, let's see. Let's see the features of biliary obstruction is what we're going to say. So we saw rejection, we saw sepsis. Yes. Now we are going to see features of chronic biliary obstruction.
So again, this is the biopsy here. This is a nice core, 1.5 centimeter to 1.77 centimeter core, and you can see we can go in the high power. So you can see this is the core. You can see cholestasis. You can see these brownish area in the hepatocytes, these yellowish areas. This is cholestasis. This is the portal area. Let's go in the portal area. What you see here, again, there is expansion. So there is fibrosis also here. You can see this expansion. There is portal expansion and edematous kind of fibroplasia. There is a lot of edema in this biopsy. It's expanded, and you can see these anastomosing ductules. Can you see these these are ductules which are anastomosing. This is biliary proliferation is happening in this biopsy because of the large obstruction distally. You can see these proliferating ductules. They are at the periphery as well as in the center of the portal area. Here again you can see these ductules, very lumen. In some you can see lumen, in some areas you can't see lumen. We'll go to the other portal areas. There's fibrosis happening. There is quite a bit of fibrosis in this biopsy. Yeah. Again, here, oh yes, here again you can see these dilated. You can see these anastomosing ductules. There is some inflammation. There are these ductules where anastomosing, forming a ring-like pattern. So there is biliary proliferation in this biopsy. There is inflammation, which is again mixed. You have lymphocytes, you have polymorphs, you have some eosinophils throughout. There is a lot of edema in the biopsy, and there is edema, and there is a lot of fibrosis. Actually, there is a lot of fibrosis in this biopsy. You can see a bridging septa, which we will confirm in a trichome stain to confirm fibrosis.
Can you show us the hepatocytes adjacent to that?
Yes, Prof. Yes, Prof.
Talk about the hepatocytes.
Yes. So here
thick they look. Yeah.
So these hepatocytes are less pink. If you see normal hepatocytes, which I have showed you, they were very pinkish. In this, they are less pink because there is bile in these hepatocytes, and which is causing injury to the and bile salts are there because there is obstruction, so everything cannot be secreted out. You can see these enlarged. How enlarged is this hepatocyte as compared to this one possibly here? This is the normal size hepatocytes, and here you can see very enlarged. You can see this pigment. Can you see this pigment, yellowish brownish pigment? This is all bile. So these are enlarged hepatocytes which have a lot of bile. This is in the hepatocytes pigment, and I'll show you in the canaliculi, the pigment in the canaliculi also. This is all this hepatocellular pigment. In some areas, Prof, I'll show them the canalicular. There is also, you can see this pigment here, you can see this very greenish pigment here. So there is a lot of bile in this biopsy, in the lobule, in the hepatocytes, and in the clavicular area. Apart from that, because there is obstruction, so because of bile, there is also necrosis of hepatocytes, and we are seeing these foamy histiocytes. So this is also suggesting that there is cholestasis going on from some time. You can see these histiocytes here with bile. There is also bile inside them. There is bile and some inflammation. Again, there's bridging fibrosis. There's again bridging fibrosis, some lymphocytic collection here. Again, there's bridging fibrosis.
You almost see a nodular formation there.
Yes, Prof. This is a fibrotic liver, Prof. This is a fibrotic liver.
If you come under lower power, you can see the nodular formation there.
Yes, Prof. I'll show you. Here you can see. We can see the boundary.
There you can see a nodular formation.
Yes. So this obstruction is going on even after repeated so much intervention. This obstruction is going on in the biopsy, and there is bridging fibrosis, even forming a biliary scarring and biliary cirrhosis. So there is quite a bit of fibrosis in this biopsy, which I'll show you a trichome stain just to confirm. So can you see a nodule? So this is trichome stain to look for fibrosis. This is a very beautifully done trichome actually, and you can see
micronodules already.
Yes, already we can see it. So there is extensive fibrosis in this. Here we can even see a nodule formation, which confirms the trichome stain. We go in the high power. This all blue is collagen. This is all deposit collagen for some time. There is some edema because you can see some light appearance also. So for pathologists, there is some edema also in this biopsy, but there is a lot of collagen has been deposited in this biopsy, forming bridging fibrosis and even a nodule formation. Apart from that, because there is obstruction is going on for some time, we can also see copper in the biopsy. So this is a good, this is the iron stain, just to show you in iron sometimes because there is no stain. So there is no counter stain. You can see bile very clearly. So if a pathologist have a doubt to look for bile in a biopsy, iron stain is very helpful. You can confirm the green bile here. So this is all confirms the bile in this biopsy, and I'll show you.
So iron stain is called pearl stain. Yes.
Yes. Pearl stain for the Prussian blue iron color. But if iron is not there, it confirms the bile, Prof.
Chronic cholestasis, we are looking for copper.
Copper. So that is copper. And if you see chronic cholestasis, you see in the periportal areas, you can see this is a rhodamine stain, and you can see these very red granules in the parocytes in the periportal. This is the portal area. You can see the ductules here, and so there is a chronic obstruction with bridging fibrosis, bridging scarring, and cholestasis in the biopsy. There is no evidence of rejection in this biopsy.
So show them the copper, the red staining of copper. It's like pepper. It's like pepper. Sprinkling of pepper. So this
throughout the periportal, yes. All these red granules are copper.
Chronic cholestasis. So this is the chronic biliary obstruction, typical feature. You also see in chronic biliary diseases like PBC.
Yes.
Similar appearance.
Cholangiopathies, yes.
Yeah, but you don't see it in Wilson's. Do you?
Yes, Prof. Yes.
Yeah.
All copper and copper associated protein, Prof. But it can be in early stages periportal, but otherwise it becomes very heterogeneous, and even in Wilson it's very heterogeneous. It's not at the same. Here you will most of the pole tract in the periportal area will show copper, but Wilson it differs from nodule to nodule.
So what I wanted to know here was, are there features of chronic rejection here?
No, Prof. No, Prof. It's all biliary changes in this biopsy. Chronic biliary obstruction.
So the plan was to do a hepatocytostomy. I think we have rescued many livers with hepatocytostomy, but unfortunately, what was the outcome here?
Prof, for this patient also further we reduced the immunosuppression as there was no chronic rejection, and we treated the cholangitic episode and planned for hepatocytostomy. Meanwhile, the patient wanted to go back to his hometown where he had another episode of cholangitis, sepsis and septic shock, and he subsequently succumbed to the illness in the parent liver transplant center.
Okay.
And move on to the next case, Prof. Next is a 34-year-old female who underwent disease donor liver transplantation on October of 2024 for PBC-related liver cirrhosis. And immediate post-operative period was uneventful, and she was discharged on 4 weeks post-transplant. And the 4 weeks post-transplant, 3 to 4 weeks post-transplant LFTs were normal. Total bilirubin was 1.1, AST of 31, ALT of 70, alkaline phosphatase of 88, and gamma GT of 90 with the tacrolimus levels of 5.4. But however, 2 months post-liver transplant, that is 10 weeks, she had an asymptomatic elevation of liver enzymes. 2.8 of bilirubin with a direct component of 2, AST of 287, ALT of 653 with gamma GT of 268 and alkaline phosphatase of 259. But she had a very low TAC level at that time. It was managed at the parent center, and empirical methylprednisolone 500 milligram daily was given for 3 days. In spite of that, her LFTs were worsening. Her bilirubin increased to 12.2 with a direct component of 7.7, ALT of 1012 with AST of 555, gamma GT alkaline phosphatase of 200 and 253. By the time immunosuppression modification has been done, and she had a good TAC level of 10.3. So in that center, they did a liver biopsy which showed acute cellular rejection. Further, they went ahead and gave 5 doses of 1 gram methylprednisolone daily for 5 days. And in spite of that, there was the LFTs were not settling, so she was referred to our center. So, comparison basis, I have written that this 11 weeks LFTs were before 5 doses of methylprednisolone, and when she came to our center, her bilirubin was 12.7 with the direct component of 10, AST of 438, ALT of 619, gamma GT and alkaline phosphatase of the same range, and her TAC level was 10.2. And we also did an extensive evaluation of all the other viral markers, and CMV DNA and imaging, everything was done, which showed a normal graft. And then we went ahead and did a liver biopsy. Over to you, Mukul sir.
Okay. This is another interesting case. So this is the biopsy. This patient was already diagnosed as acute, probably TCMR, what they say, acute cell rejection. So TCMR was diagnosed in the previous hospital. Then it came to us. This is the biopsy done. Some folds are there in the biopsy. So again, we'll see in the high power what is there. So again, there are blue areas. There are blue areas and there are pink areas in the biopsy. You see again a portal area. You can see a portal area. There is a lot of inflammation, but in this inflammation is again little different what we previously saw in a rejection. Here this is a bile duct, this is a portal vein, and this is an arteriole here. And you can see again an arteriole here. There's expansion. There are a lot of plasma cells. This is a plasma cells for everyone. A plasma cells have an eccentric nucleus with cartwheel kind of chromatin here, and there is abundant cytoplasm here because they store antibodies. They have a lot of this one. They are antibody forming cells. These are mature B cells, and you can see these plasma cells here throughout. Actually, it's all mixed with plasma. There are clusters of plasma cells in this portal tract. There is also in this biopsy, you can also see that very difficult to see the limiting plate of the portal tract. So there is a spillover. So portal, if you really want to see where is the portal plate, very difficult. The limiting plate of the hepatocyte. This is the portal area here, and there is the hepatocytes, but there is spillover. So there is interface activity, means spillover. There is there's quite a bit of inflammation in this portal tract, and there is spillover of this inflammation in the adjacent portal parenchyma. So this is so most of the portal tract show this kind of inflammation. There is some duct injury also in this biopsy. Then we go again in this adjacent. This is a central zone here. Here again we'll go in the high power. And again, there are a lot of plasma cells here. Most of the cells, again, this is again a large plasma cells. You can see very amphiphilic kind of cytoplasm. You can see some nuclear, perinuclear carrying, and this is a cartwheel kind of chromatin here. These are all plasma cell clusters in the central area. There is a lot of necrosis again in this central lobule also. You can see pericentral zone. This is the central vein. This is congestion here. This already area is congestion, and you can see these clusters of plasma cells with quite a bit of necrosis. This is confluent necrosis, severe activity in a biopsy. This is all loss. This is all hepatocyte. This is not fibrosis.
So, Mukul, if this was not a post-transplant biopsy,
yes,
you would say this is autoimmune hepatitis.
Yes, that's what I wanted to say. Yes. This is a biopsy which is post-transplant done in a patient which was not diagnosed as a cause of autoimmune hepatitis, and suggesting and presenting with a severe injury to the liver with clusters of plasma cells which are more than 30%. Actually, in this it is more than 50% or 60%, but more than 30% of plasma cells in portal area and as well as lot of in the perivenular area, which
so
is
in rejection, you don't see so much lobular inflammation.
Yes, yes.
Here you've got extensive lobular inflammation.
Extensive, Prof. Yes, yes.
Not just
this is what
total
distinguishes. Yes.
This is extensive lobular inflammation.
Extensive necrosis, extensive inflammation.
And necrosis and cell dropout.
Yes.
There is a degree of congestion as well.
Yes, Prof. Or because of cell dropout. There's such an acute injury, cell dropout. Extensive cell dropout is there. And we can also, Prof, see, and we can also see a bridging. This is a central vein here. This is central vein here, and you can see a bridging necrosis. So there is really severe activity in this biopsy with plasma cells. So this is what is previously known as de novo autoimmune hepatitis, but 2016 BRANC criteria considered this as a part of rejection, which is known as plasma cell rich rejection. There are just to tell you one thing, that apart from this, there are certain biomarkers also available which we can do a biopsy. One of them, because this is also this plasma cell rejection is a unusual kind of rejection in which is both humoral and cell-mediated component actually work together. So in this one, we can do C4D, which is negative in this, because they can have HLA-DQ or glutamine GST1 anti-GST1 antibodies. But we did IgG4 cells. So this is actually just to tell you, in this biopsy, just to confirm, this is a biomarker. IgG4 is a biomarker in an allograft biopsy. It should not be confused in a autoimmune hepatitis or something, or a native liver. In allograft biopsy, in cases of plasma cell rejection, you can see a lot of IgG4 cells. So this is a biomarker which you can see in 60% of the cases. You can see these all brownish cells. This is immunostain is done, and you can see these clusters of plasma cells, IgG4 plasma cells in the portal area as well as in the centrilobular area. So this is consistent with diagnosis of plasma cell rich rejection / de novo autoimmune hepatitis.
Can you, this is something that we described actually. Radhika, do you have a paper on? Actually,
yes, I'll just go to the
yeah, can you show that paper? Is that there that I?
Yes, sir. Yes, sir.
So this is something that
yes.
we published. What? How many years ago is that?
1998. 1998. Yes.
27.
Almost 27 years ago. This phenomenon was recognized in King. So I was one of the authors of this paper, which was published in the Lancet, where we called it de novo autoimmune hepatitis. And subsequently, it was actually described for the adults as well by Michael Heenan. At that time, it was just thought to be autoimmune hepatitis, and this no point in giving high-dose steroids, which may not be good for them. And then they were treated like autoimmune liver disease. I mean, these were the days where the tacrolimus was not commonly used. We used triple immunosuppression with cyclosporin and azathioprine. They responded to low 30 milligrams or 40 milligrams of steroids and azathioprine. So that is the original publication. And now we know that this is one form of rejection rather than autoimmune hepatitis. I think now you're calling it plasma cell rich rejection rather than de novo autoimmune hepatitis. But the histological features that you saw, if any pathologist was given this biopsy without telling it's a post-transplant biopsy, they would have made a diagnosis of autoimmune hepatitis. Okay, let's look to see how this patient's done. I think we struggled a bit with this patient, but the outcome was go on.
After the biopsy showing plasma cell rich rejection, where we did the biopsy here, we decided to go ahead with 5 doses of IV immunoglobulin, IVIG. And even with after 3 doses of IVIG, her graph did not settle. So from 18.2, it went up to 21.6 with a direct component of 18. And there was, though there was a little less AST and ALT, but the bilirubin did not settle. And tacrolimus level was also maintained at 10.8. So at this juncture, we decided to go ahead with another molecule which has been used very well in as an anti-neoplastic drug for multiple myeloma and CML, which is very specific for plasma cells, which is a proteasome inhibitor, which inhibits the proteasome, which degrades proteins and causes cell death by apoptosis. So we plan to go ahead with bortezomib, and 4 doses of bortezomib was given. And subsequently, 15 weeks post-transplant, her graph settled to 17.2 of total bilirubin with 13.2 post-bortezomib, but the enzyme levels came down to 202 of AST, and gamma GT was actually increasing even post-bortezomib. So at this juncture, you had added everolimus, and which was just started. Within 3 days of everolimus, the levels were 3.8, and the patient was stable, so she was discharged with this LFT for follow-up on OP basis. But subsequently, this was the discharge LFTs, and within 10 days post-discharge, with one visit in between to the OPD where the LFTs were more or less normal, she came with a very high level of bilirubin, 32 with 26 direct component, and the enzymes have also risen with a gamma GT of 861 with a tacrolimus level of 7.6. So she was readmitted, and again septic screening was done, appropriate antibiotics was given, there was no sepsis at that time. And we planned to start on plasma exchanges. And by the time we started the first plasma exchange after septic screening, her bilirubin went up to 42.3 with a direct component of 31 and a gamma GT level of 833. Subsequently, we planned for a liver biopsy, but by after reducing the bilirubin to below 15. So after 3 cycles of plasma exchanges, we went ahead and did a second liver biopsy in our center. Mukul sir.
Okay, so this biopsy is done after the so much therapy given. This is the core. There's a nice core. You can see it's probably a 2 centimeter core of liver biopsy, and we go in the high power. This is little, definitely inflammation is less. Not much blue areas. There's a portal tract. There's a portal tract here. There is some mild inflammation, maybe some endothelitis. This is a portal vein. It's a little expanded, this portal tract. Yeah, this is an arteriole, little distorted arteriole. This is the bile duct here, but there is definitely some injury in the biopsy. Not much inflammation. Still, you can see a nucleus loss here. This ductule, can you see there is a loss of nucleus? They are very well aligned. So there is some loss here. Also, there is some vacuolization, some in the cytoplasm of the bile duct. Here, there is mild inflammation, some endothelitis, and there is vacuolization here. Arterioles looks okay. There is no interface. Inflammation is very mild. If we go in the central zone, there is ballooning. There is a lot of ballooning. There is some cholestasis, mild cholestasis here. There is some apoptosis, but cells are really ballooned out. We'll go to another better area. Here again, you can see these balloon, very enlarged hepatocytes. They're losing their polygonal, some loss of polygonal structure is there. Their cytoplasm is very clarified or very clear, very whitish kind of rarefied kind of cytoplasm here as compared to the pink hepatocytes here. Again, this duct is okay. This portal tract is okay. Duct mild inflammation. Here, maybe very difficult to see a duct here. Maybe this, but little distorted. There is ballooning. There is some necrosis in the central lobular area. So inflammation is less. There is still some necrosis. However, you see this. Again, you see this duct, there's definitely some injury, some dystrophy, what is said, or some dysplasia in the duct, in which you can't see a nucleus. This is enlargement. There is no infiltration as such. Maybe occasional lymphocyte here.
This is so much better, though.
Yes, so much better.
There was so much lobular inflammation which appeared. There was so much expansion of the portal tract. You said there was piecemeal necrosis there.
Yes.
You said there was interface hepatitis. Everything is gone in this biopsy.
Yes.
So I would say that this is so much better.
Yes, better. But because there is some injury, vacuolization, again, this is very difficult because there is so much vacuolization, some central lobular ballooning, focal necrosis, very mild inflammation. We thought, is it going for early chronic rejection? So suspicion was that the patient, because of the high bilirubin not responding, is it going to early chronic? That was the diagnosis in this patient. Suggestive of, we cannot rule out the possibility of early chronic rejection in this case.
Okay. Karan or Radhika?
Yes, Prof, as she was responding well with plasma exchanges and with the and the inflammations were all very well reduced in the recent repeat biopsy with an early chronic rejection, we continued further 3 more plasma exchanges along with triple immunosuppression of tacrolimus and everolimus with 30 milligram of Visalone. At discharge, her bilirubin was 9.3 with a direct component of 7.6. Gamma GT has very well reduced to 303. AST of 176 and ALT of 174. And she was on regular follow-up in the post-discharge period for the past 3 months. And the last visit was 10th of this month, 7-month post-transplant. Her liver functions have come down to 1.2 bilirubin, gamma GT of 297, AST and ALT of 77 and 94, with a tacrolimus levels of 6.4 and everolimus level of 5.8. Steroids has been tapered to 10 milligram during the last visit. She's doing well.
Thank you. I don't know if I can tell you exactly how to manage these patients, but I think just patience and measures to reduce the plasma cell hepatitis ultimately has worked, I think. And to see a biopsy which was looking so much better. I know you said the cells look sick, but those cells can repair themselves actually.
Yes, Prof.
And
Yes.
I think in the long run, this is a good outcome and something for people to try and be patient with.
Can we take a few questions here?
Yeah.
So Mukul, is there a percentage of IgG4 positive plasma cells to consider diagnosis of plasma cell-rich rejection?
Matlab, yes, people have seen, they seem usually will be more than 25 per high far field.
Okay. And how to differentiate from recurrent autoimmune hepatitis?
This is not a patient of autoimmune hepatitis. That is the diagnosis. That is it. That is in the definition. The patient, you can only diagnose plasma cell rejection or de novo autoimmune hepatitis in a patient which is the native liver disease is not autoimmune hepatitis. In
Yeah, that is
autoimmune
the reason
hepatitis, if you see this injury, it would be recurrent autoimmune hepatitis. You will not label the patient as plasma
Can I
cell.
just add one or two word statements to that? So usually recurrent autoimmune hepatitis is late after transplantation. This is a rejection. So usually it occurs little early in the post-transplant phase. And also all your autoantibodies will be positive in autoimmune hepatitis. Here in the histology, Mukul, you can correct that. C4D will usually be positive because this can evolve into AMR.
50 to 60% cases. Yes,
current understanding is. So you can have
it has
high
both component. Yes.
amount of C4D, whereas
Yes.
in recurrent
We have
autoimmune
seen cases which are
you don't
C4D
see
positive.
that. Yeah.
Yes, 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 yes.
So that is one of the important point I thought.
I think the main thing then talk about, I think again, important thing is the native liver should not have autoimmune hepatitis. This can also occur late. Autoimmune hepatitis can also, recurrent autoimmune hepatitis can occur little early or little late. But the diagnosis of the native liver should not be autoimmune hepatitis. That's how you can only diagnose de novo autoimmune hepatitis.
But that's what the question says. If the patient was a case of autoimmune hepatitis,
then it's a recurrent autoimmune hepatitis. Then it's a recurrent autoimmune. You have to treat it like a recurrent autoimmune hepatitis.
Right.
You cannot diagnose a de novo autoimmune hepatitis in a patient whose native liver biopsy is autoimmune hepatitis. The definition doesn't allow that.
But
so
sir,
should
in
we
case,
be doing?
Sir, in case the patient, the biopsy, native liver biopsy has not been there available, and we don't have the information of the primary diagnosis of AIH, in that case, what do we diagnose?
No, you have to know the diagnosis. I don't know you. Then you have to say that we are dealing with a severe immune-related injury which is rich in plasma cells. I don't know how to really answer this. You have to really formulate the diagnosis in such sense that if you're not aware, because it's in the definition, you can't go against that. You can only diagnose these cases when there is no. If you don't know, then you have to say if you are not aware, then you have to write that there is a severe immune-mediated injury. That's how I will write, which is rich in plasma cells. And probably I can put a comment also that if it's not autoimmune hepatitis, then it is PCRR or de novo. If it is a case of autoimmune hepatitis, in the later you should review, if you can get the biopsy, you should say that possibly this is a recurrent autoimmune hepatitis.
I mean, by definition, this is de novo.
Yes, so that's.
So you can't diagnose through this. Yeah, it can't be recurrent.
So good evening.
Yeah.
Prof. Dr. Pari here.
Yeah.
A fantastic case. So the last slide showed that the SGOT and AST and ALT had come to like 2 times the upper limit of normal.
Yeah.
So are we happy with this, or are we still looking for complete normalization of AST ALT? Does it mean that?
Yeah, that will take time. See, I would say if you look at the biopsy, you will have cell death and repair over a period of time. All of those sick cells over a period of time will die out and will regenerate back.
Yes.
So you just have to give it time.
Yes.
If the liver biopsy looked pristine, that's another thing. So all those balloon cells over a period of time will die.
Yes.
So your enzymes are going to take some time to settle down to normal. Yeah, I mean, if you ask me in 6 months' time and in a year's time, there is ongoing rise in the enzymes, and if it doesn't settle, I would predict that this patient will go fibrotic over a period of time.
Yes, and rejection. Yes.
Okay, so that means there is an ongoing injury to this graft with whatever form it is. So a continuously high enzyme, twice normal or 3 times normal over 1 or 2 years period, if you do a biopsy on them, you will start getting fibrosis in them. So
so in 2-3 months time, if the AST, ALT are still like around 2 times the normal, do we biopsy again, or does
I
it?
guess so. I think in 3 months' time or in 6
You may
months,
go into CR. Yes, we may go into chronic rejection.
Yeah, you may want to know what's going on
Yes,
in the liver.
Right.
That only tells you about the longevity of this liver. A persistent injury to this liver will result in fibrosis over a period of time.
Dr. Dugal, you were making some comment.
Dr. Mukul, what I want to understand is, like, I know you were doing a lot of renal biopsies before, and we used to see tissue ANA staining whenever we deal with autoimmune kind of conditions. Have you tried doing IgG on the frozen section just to see if liver shows in cases of autoimmune hepatitis or de novo kind of diseases, whether tissue ANA staining will help in these kind of scenarios in liver?
No, we have not done it. We have not done tissue IF in these biopsies. I think many times in de novo, the ANA, and you have ANA and ASMA positive, so that does not distinguish this. Even if you do these markers, these ANA or ASMA in a patient with TCMR, that also might be raised. So that's why the definition doesn't talk to you about these serological parameters. You can have positive or negative. The diagnosis rests on biopsy only. And the biopsy suggests that you need to see plasma cell rich rejection, means plasma cells, which usually are more than 30%, and sometimes they are actually 80%. And you can see some biomarker positivity, either C4D, either IgG4, or both, or sometimes even both can be negative. But diagnosis rests on plasma cells in diffuse involvement, portal involvement, central lobular involvement, a lot of necrosis in central lobular necrosis in the biopsy, and in inflammation, which is plasma. So that is the diagnosis. Rest all you can consider for academic or other purposes or research purpose, but that does not come in the definition. Definition is just based on histopathology.
Okay, and my second question is, like you mentioned about early chronic rejection. You raised a suspicion of early chronic rejection because of degenerative changes in the bile ducts. So that is based only on the degenerative changes. Even in the absence of, if there is no loss of bile duct, then also we would raise a possibility of early chronic rejection.
Yeah, you don't need to see a loss in early chronic rejection. You don't need to see. Degeneration is enough.
I mean, I think you don't need to be very firm on the diagnosis of chronic rejection here. I wouldn't have said this is absolutely chronic rejection. I mean,
suggestive that because of the
suggestion that it might progress to chronic rejection.
Progress, yes.
What he's talking about, which is why we added everolimus to this.
Yes.
Kept on it. So you never know what everolimus did to this patient. I personally think it's everolimus which has helped in the long run for this patient.
Yes.
Can we move on? Please? How many more cases have you got? Shall we
One
do
more. One more, Prof.
Okay, all right. Okay. I wanted to complete it in 1.5 hours because it's going to be 2 hours now.
So this is a 42-year-old male, ethanol-related liver disease, ACLF presentation, underwent a living donor liver transplantation with a good graft, GRW of 1.432 ducts in a cuff. Had a smooth post-op period, recovered well, he was discharged, regular clinic follow-up for the first 3 months post-transplant, and then discharged from the clinic. Initially maintained a good male follow-up for the next 2 months and then lost to follow-up. So this the initial set of labs and the discharge labs. If you see on clinic discharge, his bilirubin is 0.24, AST of 30, ALT of 24, gamma GT of 31, TAC level of 7.6. So good graph function on the clinic discharge. After 6 months, he comes back to us with a history saying that he started to work on a ship and he missed his immunosuppression medications for the last 1 month. And he did not have enough stock on his ship along with him. So when he came to us, he came 9 months post-transplant with a bilirubin of 22.5, AST of 234, ALT of 140, gamma GT of 2300, and undetectable TAC because he's never taking it. And he clinically was ectric, otherwise no other signs and symptoms. So we at this point of time did post-transplant viral screening, which turned out to be negative, CECT abdomen, which showed a good graft, Patent results, no IHBRD. And hence we went ahead with the liver biopsy for him.
Okay, so I'll show you the liver biopsy. Just a second. Okay, so this is the core. This is again a nice core here. You see this liver biopsy, and not much blue areas, mostly pink areas. Some pale areas you can see, definitely pale areas. So we'll see in the high power what are these pale areas. Let's see what
So this is a real surprise that somebody who stopped immunosuppression for 1 month doesn't have intense inflammation in the biopsy.
Yes. So, Prof, in this biopsy, so you see this is the portal area. There's not much inflammation. This is a portal vein. There's an arteriole. This is the duct. There is some injury. Even that's why it's important. Even when there is a very slight inflammation, you can see some injury in the biopsy. There is loss of nucleus, possibly apoptosis. There is some disturbance of polarity, not much, but there is mild disturbance of polarity in this biopsy. Maybe because there are some collections of foam cells. You're not seeing much of inflammation, but there are foam cells in the sinusoids. So we'll see how this biopsy. Then again, we'll see this is possibly a portal area. This is a portal area here, very not convincing. This is a central area. Here you can see necrosis. There is cholestasis, there is necrosis. Again, no very mild inflammation, very sparse inflammation, but there is necrosis around these centrizonal areas, and there is cholestasis. You can see these greenish. This is all bile in the hepatocyte as well as in the canaliculi, and also probably there is also spillover in the sinusoids with Kupffer cells also have some of the bile. So here you can see that. So there is quite a bit of cholestasis here. Some apoptosis is happening. Very mild inflammation. In other areas, yeah, you see this portal tract here again. So here you see this duct, definitely a little injured duct. This is an arteriole. This is a duct. This looks like possibly a duct with loss of cell here. This is an arteriole. This is again a duct, and this duct, you see this very difficult to see lumen. Again, disturbance of polarity, very mild inflammation in the biopsy in this case. Yeah. Collections of foam cells. Now this is what we talk about when we see these kind of changes. This is a biopsy which happens late. Person has missed in immunosuppression, not much inflammation, but there is necrosis, not much inflammation. So this is actually considered little ominous, that when you see these kind of necrosis with very mild, if you see trichome, very mild fibrosis, mostly necrosis, some congestion around the central vein, this is actually a sign that maybe patient progressing towards signs of we are seeing chronic rejection. This is because there is no duct loss in the biopsy. Here again, a small portal tract, not much inflammation, very difficult, no duct is seen here. And let's see here again. So again, portal area, this is a okay duct, but this duct is again injured, very dysplastic kind of duct, elongated kind of duct here. Cholestasis, necrosis. So with this biopsy, there is no inflammation, but there is centrilobular, there is necrosis, this kind of necrosis, a lot of cholestasis in the centrilobular area, and duct which are showing some dystrophic changes. We suggested that possibly we are dealing with early chronic rejection.
With this patient, next, we gave a trial of pulsing with steroids for 3 days with 1 gram methylprednisolone, continued for 2 more days as there was no poor response. Tacrolimus was restarted at 2 mg BD, and MMF was also given at 1 gram BD. So his presentation bilirubin was 22.5. After pulsing, bilirubin came down to 16.5, but after that, on day 5 of pulsing, the bilirubin did not respond much. It was 16.03. Enzymes almost fairly the same, 225 of AST and 292 of ALT was going up, and a gamma GT of 2961. TAC level came around A6.8, and steroids of 20 mg were given, and MM of 100 BD. 3 days post the pulsing, the bilirubin further went up to 19.9, and the enzymes were also on the higher side. So at this point of time, we added everolimus as well at 0.5 BD and stopped MMF. So when you see 2 weeks post steroid pulsing, the bilirubin went up to 25.8. So it is almost higher than the bilirubin which he presented with. And enzymes also on the higher side, 304 of AST and 366 of ALT. Gamma GT has almost gone up to 4,153. We were maintaining a higher dose of immunosuppression with combined TAC and everolimus levels of around 14 and steroids of around 30 mg. So 3 days later, the bilirubin goes up to 28, and hence we decide for giving ATG for 5 doses. And 2 weeks post ATG, there is not much of a drop in bilirubin, it's just for 28 to 26.2. Enzymes again remain at 215 and ALT of 316. And the gamma GT of 4,500 with the TAC and everolimus combined levels of approximately around 14. Because of prolonged steroid use and high dose of steroids, probably developed acute glaucoma changes and then steroids were tapered after that. 4 weeks post ATG, if you see, the bilirubin has a declining trend, but the enzymes are almost static. Gamma GT going up to 5,630. And gradually the steroids are being tapered. Over here, we were patient, we were waiting because the bilirubin was coming down slowly. Though the enzymes were a little slow to respond, but every week LFTs were being repeated. And 8 weeks post ATG, the bilirubin came down to 21.7 and AST of 177 and ALT of 141. The gamma GT2 dropped from 5,630 to 2,357. And gradually the immunosuppression, the steroids were tapered. So this was almost now 6 months post the treatment of rejection. So after his presentation, after the stopping immunosuppression for a month, it is almost 6 months now. So we wanted to just look at the liver. So a CCT was done. We showed a good graft and patent vessels and no IHBRD. So we were positive in continuing the same treatment and patiently waiting. And we were doing LFTs every 2 weeks. Over here I compiled monthly follow-ups for him. So the bilirubin was 20.7 and enzymes 124 and 54 of AST and ALT, and a good TAC and everolimus levels. Gradually, if you see, over the period of next 4-5 months, the bilirubin has come down significantly, and the latest follow-up, the bilirubin is 0.9, AST of 38 and ALT of 15. Gamma GT is still slightly on the higher side on 600, and TAC level of 8 and everolimus of 3.3. So it almost took around 8 months for the graft to settle since the stoppage of immunosuppressants by the patient.
Yeah, this is a lucky patient, actually. I think most often this patient would have really resulted in retransplant. I think in the Western world, this patient would have had a retransplant because a cadaver transplant would have been available. In our country, I think financially and in terms of donors, it's not possible to offer retransplant. So we need to try all of these methods. And I would say here is a situation where we have not actually paid much attention to Mukul. Because the first biopsy itself showed no inflammation. So we shouldn't have expected any improvement with high-dose steroids. Pulse steroids had no effect because there was no inflammation to take out. But it's then very hard not to give a standard treatment of rejection in somebody who had stopped immunosuppression for 1 month. So the assumption is that this is an acute rejection. I would say the ATG was probably an overkill, and the ATG didn't do anything to this patient. I see the perivenular cell dropout. I mean, what you see, those hyalinization, actually it's a long scar, actually, that is. I think the cells have dropped out, and then you see them as a scar, really. And that can be because of the arteriopathy. So you see, in chronic rejection, the inflammation resolves over a period of time. And with the chronicity, you get a bile duct damage, you get the high gamma GT, and you get the arteriopathy. And the arteriopathy results in cell dropout in zone 3, which is furthest away from. So it's an ischemic insult, really, which is resulted in the low-grade enzyme rise. It was really patience and treating chronic rejection, which has reversed it. Putting the patient back on immunosuppression and allowing repair to happen. And that is what has improved the situation. I don't believe, I mean, I think we had no choice but to give steroids. We should have given the steroids, but maybe we should have avoided ATG and just waited. And if situation was like in the Western countries, this patient would have had a retransplant and probably done well with a retransplant as an intractable chronic rejection. So he was lucky to get away with this. That's all I would say. I don't know whether that is a lesson or not. We could have got into trouble with him, and if he had got septic, he would have died. Okay, and that's it, I think, from us. And if anybody wants quick questions, I'm grateful, but I think we're coming close to 2 hours, and I don't want to bore you guys with too much pathology either.
Yeah, no, it was actually really interesting, man. I think the way the questions are popping up, I think if we can go on for many hours like this, and that gives me an idea that this is something which I think people would be interested on a regular basis. I think Dinesh wants to say something.
I mean, Prof, would you say that when we deal with patients with rejection or graft dysfunction, you make one change and wait for some time to see whether the change works or not, rather than doing multiple changes at the same time and then ending up in trouble? Is that?
I think so. I think patience helps. See, we do get a lot of patients who've been transplanted elsewhere, who come in desperate situations. And I've seen many patients who've come to us and died, and many patients who've come to us and survived just by optimizing immunosuppression and not being too aggressive about it. And the common theme I see in most patients who come to us is they've already had everything thrown at them. They've had their ATG or OKT3 and very high doses of steroids. It's unbelievable how people are desperate to treat them, and that really harms them a lot. And the lesson from this episode should be that don't make drastic decisions without doing liver biopsies. Find out what is going on. And most of them are for some reason afraid of doing liver biopsies. And just trying. It's all about trial and error, empirical steroids, empirical, this has to be rejection. And that many patients come very sick to us. And very often actually withdrawal of immunosuppression. I know Karan will know, he's in my clinic a lot, and Radhika is in my clinic a lot. We have clinics like an MDT in our center. So when I'm doing clinics, there are about 2 hepatologists and 2 surgeons with me. So we see that just withdrawing immunosuppression improves a great deal of patients actually, which gets them away from sepsis. They feel much better, and that builds confidence in the patients in us. That's a very common theme I've seen. So use pathology as much as you can to make decisions, and be patient with these patients. If they don't get septic, they'll be okay. If they get septic and they are in hospital, it's done. I think you can't rescue them. And most of these patients are actually managed as an outpatient with very abnormal liver function tests.
I think there are many more questions, but I think in view of time, I think we should close. And I would like to thank Prof Rela for his expert words and wisdom, and we learn a lot from his experience always. Would like to thank Mukul for pathology insights, Radhika and Karan for presenting the cases, and all the participants to help us making this entire event so engaging. And we are going to have these kind of sessions on a regular basis. And we also plan to have a transplant pathology symposium during the annual meeting in November, LTSI annual meeting as well. And that is something we are working on the entire plan. And so, as I said, this is going to be a regular thing, and we'll keep you informed when we are going to have next sessions like this. So thanks a lot, everyone, for joining in, and thanks, Prof, once again. And hope you all enjoyed, and do send us the feedback if you want anything else in the masterclass. Thanks a lot.
Thank you, guys. Thank you very much. Bye-bye.
Thank you.